sound effect, Beanie?
Ooh, I don't. But no, I don't. Fuck. This is the only.
I was like, do we have intro music?
What is this?
Apparently, we do have an intro music. I didn't know that. But anyway, welcome everyone to the Random Anesthesia Topic podcast.
Holiday podcast.
Yes, the Random Holiday podcast. I don't know. Tonight we have Dr. Natasha Bertel from King Animal Hospital in
Jingle,
Ontario.
jingle.
And then we have Dr. Ryan Bailey from Premier Veterinary Group in Chicago.
Apparently.
Hot Dog City. So tonight is going to be Dr. Ryan Bailey unveiling his random topic. We have no clue what he picked. Kind of scared about it.
Look at his dirty little face. He's so excited to antagonize us, which frankly is not very holiday-y in my opinion.
It's not very nice of you.
Even though I'm not in green.
No, but we're all balanced. We have each one of the holiday colors. Yeah.
We are,
That's true. We didn't organize this. We didn't pick the colors. I have no clue what you were wearing.
Well, we wanted to order shirts, Beanie, but because of the Canada postal strike, we wouldn't have been able to coordinate anyway. Thanks a lot, Canada. But yeah, they said all I want for Christmas is ketamine, and we were like, yeah.
Okay.
Is this the part where we put the disclaimer in that says nothing that we say or do we can be held liable for?
Well, I can see why that wouldn't make it through customs, but
no, don't be ridiculous. It's legal up here, guys. I can get ephedrine and you can't.
True.
Yeah.
More drugs somehow. You have some sort of Canadian exception. You can be like, we need this.
That's right. That's right. We need ephedrine to get through cold season in the Great White North.
Cool.
Sure.
How else?
For sure.
Yeah, that's what we tell customs.
Jesus Christ.
Well, I hope you are all ready because I have a great topic based on some of what I saw in ABA, plus some of the recent literature that's out in VAA. So I want to know what your thoughts are on total intravenous anesthesia.
Oh. All right.
First of all, I don't read any literature, so this is going to be tough for me.
I'm surprised you're literate.
Okay.
It's a Canadian system.
Yeah, we don't need literature. By the way, listeners, JK, I do read literature, JK. But yeah, no, I think Beanie, why don't you field this one?
Well, I mean, to be honest, I love it. Right? I read a lot of the human literature on it. I think it's far superior, to be honest with you, compared to inhalants. They wake up better. I think a lot of people don't realize this, but a lot of the dysphoria and the post-operative nausea that our patients get actually comes from the inhalants, right? People always...
A lot of the nausea that I get from being an anesthesiologist is probably from trace isoflurane.
I have post-op nausea and vomiting myself. I threw up for 24 hours straight every 2 hours when I had my wisdom teeth taken out. It was a nightmare.
Are such wimps, honest to God. I have had every anesthetic drug, and I wake up like a rock star.
Nothing about me is wrong. Everything about me says wimp.
Well, so I think I had 7 anesthetic events. 4 with gas, 3 with TIVA. And the 4 with gas, I puked the hell out of it all night.
Ooh.
Every single time. with TIVA, like, they bring me back to the room and 20 minutes later I'm walking. The last time I had bilateral inguinal hernia repair, and I asked them, I was like, can you do that propofol Remy? And it was like, sure, why not? And it was amazing. It's, I, a lot of people don't realize that, but the dysphoria and the vomiting and the nausea do come from the needles. The other side of things, though, is that it's a very different anesthesia, right? So, like, anesthetic signs are somewhat different. Your palpebra is usually there all the time, like regardless of how deep your patient is. Sometimes propofol and alfaxilin, they both give you myoclonus, and alfaxilin is somewhat more in recovery, propofol usually more during anesthesia. And so, like, people think, oh my god, the patient is light, and then you give more propofol and then they get more myoclonus. They go into
I
that
love that for
spiral.
them. Yeah.
They go into that spiral. So usually, and I do always try to get my students to kind of like try it at least once during the rotation. And I always tell them the major sign you're looking for is probably jaw tone. That's probably your best anesthetic sign with TIVA. The twitchiness and the palpebral, you're going to see that, unfortunately. There are some reports of unstoppable myoclonus. I think from 2000 in Italy, actually, they described that, where they had to just wake them up or paralyze them. But besides that, it's pretty rare. I've never seen it. They do it way more often in Europe, and in Italy, actually, there's a pretty big movement on doing TIVA for our patients. Some of them use TCI, which has its own limitation, but it's a useful tool, and a lot of people actually probably don't even know what TCI is. TCI, for whoever is listening.
I'm just kidding.
For whoever is listening, TCI stands for target controlled infusion, and basically the pharmacokinetic model, it's loaded into a computer, and the computer drives the syringe pump based on some parameters you set and decide. Oversimplifying, more or less, that's what it is.
Yeah.
But FDA never cleared it in the US.
Yes,
in Europe,
another,
they use it.
Can't get ephedrine, can't get TCI. South America.
But yeah, it's good. I like it. What about you, Tasha? What's your thought on TIVA?
Oh, my thoughts on TIVA. There are many. Also, I just want the people who can't see us on podcast tonight know that we're all enjoying some eggnog tonight. And every time one of the other anesthesiologists says something that annoys me, I like to take a swig. So I do also want to bring up, while I have an Italian and a Chicagoan on the line here, is pizza. Thin crust or deep dish?
Thin. Clearly thin.
You're probably, are you the only person in Chicago who's not going to like live or die by deep dish?
Oh, there's a movement in Chicago about this tavern style pizza where it's like super thin crust. It's like a cracker underneath. And then you get the corner piece that's like, it's almost like a tortilla chip of pizza. And it's like truly the greatest thing. It's like, it is an abomination to what Italians consider to be pizza.
Too bad you guys can't see Gianluca's face, because it looks like he's passing a kidney stone.
Horrified.
I saw his face and his hand was just like this. I was like, oh my God, he is like dying. But no,
I think it's time for everyone to take a sip of eggnog. Yeah, take a sip of your eggnog. But yeah, no, I thought
style all day.
I was like, because I know Beanie's still recovering from the whole "don't put ketchup on your hot dog," and I thought Bailey, you were going to come out swinging about deep dish, but then I forgot you're a pizza freak attack.
Other style in Chicago that is like ubiquitous, and it is just like little tiny squares of pizza. Like you take a big pizza and you cut it into like little tiny squares.
Oh,
they're thin, they're crispy. It's like crispy all through. It's not like soft at all. It's like a cracker underneath.
Can you eat crackers instead of ruining pizza?
Hey, it's Chicago. We gotta do it our own way. We're gonna ruin any kind of food, Wait, I just realized. Have you ever heard of an Italian beef?
Italian beef.
Yeah.
I mean, we do
Oh,
have
guys,
cows. Yeah,
where
there
is
is
this
Italian beef
podcast
for sure.
going?
So, there's a sandwich in Chicago. It is a big hunk of beef, like a roast. It's roasted with herbs and spices, and then they slice it up real thin and cook it in this gravy. And then they take a French bread roll, they stick the meat inside, and then if you want it dipped, they'll take the whole sandwich, meat and all, and they'll dip it into the gravy, pull it out, and then they put these hot peppers on it called giardiniera, which is like I don't know if you have it there, but in Chicago, it's like oil and peppers and olive oil and carrots and cauliflower.
Is
It's
Chicago the heart disease capital of
oh
America?
my god, yeah.
Yeah,
That's
no,
the whole
I
thing.
thought I would just, yeah, I was like, that's sort of how I feel.
Like,
Beanie's face reacting to your cracker pizza is sort of how I feel about inhalant anesthesia. So that's a great lead in for my TIVA talk. Now, I will admit that TIVA sometimes is a pain in the ass because, especially if you're doing it, for example, like on an MRI and you have to run 95 lines and, you're pushing, enough propofol through to drop a hippo. So from a pragmatic standpoint of view, like I get why when we asked for TIVA, like, the nurse technicians are like, ugh. And I remember as a resident, in the middle of the night, just being like, this is just, the worst. But I mean, I agree. I think that, for the most part, unless you're a cat on a long-term alfaxalone, the recoveries do tend to be better. I think the cost differential is probably comes out in the wash at this point. And the other thing too is that especially Bailey and I have definitely gone toe to toe about whether or not you use this in thoracotomies. And of course, it depends. Like, do you have a punctured lung? The likelihood of a ruptured lung? Are you taking lung out? Like, is there a risk of inhalant leaking into the room? But more importantly, like you have to remember inhalants deregulate hypoxic pulmonary vasoconstriction. So actually being on an inhalant can in fact worsen shunting of the, deoxygenated into the oxygenated circulation. And, you may contribute to overall drops in your partial pressures of arterial oxygenation. So that's a nice consideration, especially if you do have underlying pulmonary pathology, or you're going to have marked atelectasis, or you're going into the chest and the lungs are going to want to continually collapse against loss of negative pressure. So, I like TIVA. I will admit that it's a pain in the bahookie. But yeah, I mean, I think a lot of people would cite like it's better for the environment. And I think that is a marked overstatement of like how much isoflurane am I putting out into the atmosphere, contributing to the depletion of the ozone layer versus, oh, I don't know, major industries churning it out like, in millions of gallons a day. Like, I'm not losing sleep over this. So, do I think I'm making a long term difference in the outcome of the planet switching over to TIVA? Probably
No.
not. But, whatever gets you through the day. But yeah, I think TIVA definitely has its place, unlike tiny crispy cracker pizza.
oh no.
No, no.
So,
Wow.
so,
You're
so,
gonna need
so,
more eggnog. You're gonna need more eggnog.
wait. So, how about hot dogs on pizza?
Oh, I have done a hot dog pizza. I made a Chicago style tavern pizza and then I put all the hot dog toppings on it. I bought pizza like that. Oh my God. So good. So good.
Remember, was it episode 1 where we determined that Ryan was for sure going to die of heart disease? And
Oh, for
I
sure.
want to loop back to that comment right now.
100%.
Yeah.
That's why I went on a run today. I gotta run so I can have the hot dogs.
Now
Sure.
there's a t-shirt. Now there's I run for hot dogs.
I'd also like
Run for
everyone to
hot
know
dogs.
this eggnog is from last year. So if I die in the middle of this podcast, that is the reason. And it tastes so good.
Poor baby.
Holy
Beanie's
shit.
gonna have to take it on Dancitron shortly if you don't stop. But I do like
No.
your fancy eggnog glass, Bailey. I know you've got the whole gamut of cocktail glasses.
I do. These were a gift to Carolyn last year.
Oh, and they
Aw.
nog specific, or will you also do like a grasshopper?
I've never made a grasshopper, but a grasshopper could go in there for sure. These are a little
I love
smaller than
grasshoppers.
the other martini glasses I have. These are like a 3 ounce, so
Would you
I
put
don't have to
grasshopper
like
on a pizza?
probably like real grasshoppers maybe if I got some. I've not eaten many bugs. I don't have an issue with it. I mean, I do have an issue with eating spiders, but like I'd probably eat a bug.
I've eaten bugs. I've had
Yeah,
worms, but you are correct. I've steered clear of the arachnids because I feel like that's just something that they're just trying to pull the wool over the eyes of tourists and see who's dumb enough to eat a tarantula. So absolutely not.
Yeah, no, not for me.
Yeah, no, I don't think
yeah,
we should continue this. The Italian, I think, is going to have a stroke soon. So,
Yeah.
so Bailey, I'd like to hear your TIVA remarks because I know you're just like
yeah.
So
itching.
no, I feel like I'm a bit of a late adopter. We did TIVA as residents, and it was more under the realm of like this is a technique that is possible. It is indicated in such and such cases, but essentially is not like it is not a mainstay. I would quite I think I think it is I don't know if mainstay is the right word, but I think it's an appropriate technique for any case undergoing anesthesia, maybe except the long term cat anesthesia case, because cats are unique little creatures. But like, I think using injectables, propofol, Faxlone in dogs for any kind of procedure is reasonable. And I find the anesthesia is much smoother when I add it. Like, I will say, I'm still inhalants, like that is the primary way I anesthetize most of my cases. But I just wonder, I think the reason I brought this question up is I wonder if that's right. And I think the answer is it's probably not as right as we think with the advent of propofol and
You know, you owe me an apology because like 4 or 5 years ago, like you ripped into me about Tiva versus inhalants because of course you were trained at Davis and like
sure.
they move in terms of medicine at like glaciers have melted more
Oh
quickly.
yeah. Yeah.
Probably, because of inhalant anesthesia. So, yeah, I think that, yeah, I feel like I was like, Bailey, what are you talking about? Like in human medicine, they use TIVA all the time, and like it's so nice, and like there's no waste anesthetic gas. And you were just like,
Oh
it's
yeah.
not indicated, Bartel. It's totally broken. And I was like, okay,
Oh yeah.
like you do you.
I I apologize for any overly emotional debates I may have gotten into. Like I like in clinically, I will say I find these cases that are really challenging to manage with inhalant and injectable alone. And if you switch them to a TIVA technique, it's smooth sailing. Blood pressure is stable, patient's stable, they're not moving. I can get them off pressors. We're not fluid bolusing them into oblivion. We're not having to reach for atropine. And I'm sorry, I don't have enough knowledge of the inhalant, pharmacokinetics to really have the best example. But my idea is that there's some sort of gradient issue from the lungs taking up the drug and equilibrating with the brain, and it's not going the way we predict it to. We rely so much on this like favorable equilibrium equation that I don't think is always true, and especially in those patients who maybe have some degree of inflammatory lower airway disease, they seem to just be really challenging to manage under anesthesia, and you convert them to a Tiva or even like a Piva with like a whisper of ISO if you don't want to like make people kind of freak out a little bit. But I've really been liking it, and it is a quick, I'll give the patient one or two. Mm, if they're rollicking under anesthesia with ISO, they're super tachypnic. They buck the vent as soon as I start it. I repeat an opioid dose. They have a block on board. It's okay. We're reaching for injectable now. Do we do PIVA with like, lidocaine, dexmed, ketamine, something like that? Or do we just get rid of the inhalant, transition to propofol, and see how it goes? And the results in my hands have been really good. And reading just some of the human stuff, it seems like it's much more common. Like it would just be like,
Hmm.
oh yeah, I felt like using propofol today and not like using ISO. And I feel just at least clinically where I'm at and where I was trained, and just kind of reading the survey that came out in JAVMA or in VAA 2024, it seems like we're still there of like TIVA is a technique that we have access to, but it is not the mainstay. And my question is, why aren't we doing 50% of cases, on TIVA? Like what's the barrier? I mean, they speculate far more on like what the barriers to using TIVA, but I really think I don't know. I think it's
Laziness.
I'm really happy with it.
A
And
lot of it is laziness, I think.
yeah,
You
I
I think
think
know,
that,
moving the needle for veterinary anesthesiologists is like, it's
yeah,
like shifting Atlas's, earth
case
on
in
the
point.
shoulders. Like it is moving the needle in our group is agonizing because we take evidence-based medicine to the point where it becomes paralytic. So
Well,
I think
so
that's a
that's the
hurdle.
interesting thing is, so what are the advantages and disadvantages to TIVA? So like, what do you think? Like, what is your understanding of the knowledge or the literature surrounding hemodynamic stability? Since that is 90% of our job is
much
balancing.
better.
So
It's
yeah,
much, much better with TIVA. We do know that you have way less chance of having hypotension with TIVA, right? And that's both reported in humans and in dogs. And there are some species where I remember one night I was called in during my residency to anesthetize a ringtail lemur for a gallbladder mucocele. And the first thing, wait, the first thing I read, I was like, holy shit. I mean, I've seen them just in pictures. Like, I've never actually seen one live, right? So
Well, Beanie, if isn't that the story of all of our jobs? Like,
a
today I
lot
got
of that.
asked, how many times have I anesthetized a silverback gorilla? And I was like, just the once.
Fair, fair. And but one of the things I was reading is that they're super sensitive to inhalants, right? And so,
They're monkey
which I
primates, right?
mean, yeah. And so, what did we do? It was like propofol remifentanil.
yep,
Perfect,
yep.
legit, amazing.
God, the last time I did a lemur, Beanie was a resident.
Uh,
Um, I always had really good luck with Tiva. I think it's really good.
yeah,
I think part of the disadvantages are that, especially in academia, the way we price things
yep,
is that we have packets like level 1, 2, 3, or whatever, or some sort of packets like that, and those do include inhalants, right, in the price. And so,
yep,
if you were to use propofol, you have to charge extra
yeah.
for the drug, right? So that makes it more expensive, right?
Totally, yeah, for sure.
To a degree,
Yeah,
whether it's relevant or not, it doesn't matter.
right.
But it is this much more expensive.
Yeah,
The other side is that there is the setup, right? You need the pump, you
yep,
need the lines, you need the syringes, and
You need extra
people,
IV access, right? Like that
yeah,
might be a
right?
practical limitation if you're struggling with IV access, for example. Like it's
yeah,
I mean,
markedly
you do need IV access
in heart
anyway, right?
failure, so it's vasoconstricted, or it's markedly septic and hypovolemic and all those other things.
Mm.
Like IV access can
Yeah,
be a limiting factor if you're going to run not just like single agent
yeah.
TIVA,
And,
right?
and that would be the other thing I'd add is like really propofol tiva in at least in small animal patients is probably not it's not the best. Like it's probably going to be a multi infusion. Like you're inherently going to reach for balanced anesthesia by doing tiva just because they become so, like, unless you're willing to really max out that propofol dose and be slamming 600 micrograms per kilo per minute into them, which is just, you're just going to chew through drug and bottles and stuff.
right.
It's not really sustainable. So you're going to need an analgesic infusion, potentially a muscle relaxant, potentially. Like you're going to need to have multiple pieces in the puzzle there.
Yeah.
So that
But that's
adds,
what makes it fun, right? Like I didn't become a veterinary anesthesiologist to just give midazolam all the time. So like, I mean, like mixing it up. And I have heard anesthesiologists say, I don't like to use multiple drugs at once because I don't like to have to think about what they're doing. And like,
Isn't that what we're paid for?
Well, that's, I was about to say, like, I was like, if I had one of those like vaporizer guns that they do in comic books, I'd be like, boop, you're off the planet. But yeah, like that's the whole fun of it is like, for me anyway, is the challenge that you want to hit that nice like autopilot plane and not
Which you
slow
can
down.
with TCI, by
Yeah,
the
yeah,
way,
yeah.
right? That's
Just another
exactly what you
example
can
of
do.
robots taking over. But yeah, no, the other thing too is that like when I did my human rotation, which we chatted about, I think before the recording started, for example, like the burn unit only used TIVA.
Really?
Yeah, because they didn't want to give anything that might be caustic or might induce hypoxic pulmonary vasoconstriction, like deregulation. So they would not use inhalants because if
Sure.
there was smoke inhalation from a burn victim or what have you, TIVA was the protocol of choice. Like they didn't even have vaporizers on that floor. Yeah, and I mean, it's also a nice option too for like, MRI because then you don't have to buy specialized like non-magnetic equipment and but you do need to buy a lot of plastic lines, which
Yeah.
no, sorry Pacific. But yeah, no, I do think it's an underutilized technique. And I get to like in GP that you're not going to do that because most GPs don't even have one syringe pump. Never
For sure.
mind. Like, what's your personal record for case syringe pumps? Like mine's like 13 or 14.
Oh, I don't think I
Like, yeah.
that. No way.
Similar,
Yeah.
similar. But you know,
Sorry, let me correct that. That's not all like drugs for TIVA, Bailey. Like, yes, I do this very fancy, it's called the Bartell protocol, where I titrate doses of every known anesthetic agent to the
Oh
bare
my
minimum and
god.
give it all at the same time.
Perfect.
Yeah, summer Peter
just a
Pasco
sprinkle
is
of it.
You
dying.
don't even have to think about it.
No. I mean, yeah, you just put fentanyl at 40 and go for lunch. It's fine. But yeah, like I think yeah, I enjoy a good TIVA case. I don't know.
I don't know. I like I feel like should it be should we be, like with where they're at in humans and the amount of TIVA they're doing, is there going to be a trickle down effect? And assuming this podcast goes for, 10 years. In 10
No.
years, are
I
we going to
mean,
talk about should we be using more inhalant and stop doing all this TIVA?
I guess that
Maybe.
depends on who you ask. I mean, we went through a 2-hour AGM recently and made 0 decisions as a collective community. So I don't have high hopes, Bailey, but yeah, I do. Disclaimer. Anyway, but yeah, I think, we could set a new standard. We could have our own little private, we could form our own regulatory college and set new standards. Like, I'm all for it.
So
Sure.
what are your favorite name a species, give me your favorite TIVA plans that you like that you're using, on the regular. What do you like? What do you use? When do you
God,
use
every
it?
time I do a lemur with a mucosal, I 100% do propofol and Remy.
I'm definitely going to do that from now on, for sure.
Yeah, like I was struggling with my lemur anesthesia before, but like I hadn't thought about Remy, and that makes a lot of sense.
Yeah.
So yeah, like King Julian, Maurice, like bring it on. Shout out to my favorite lemurs.
Name.
Okay.
Oh,
Your
poor people.
favorite
You don't watch
lemurs?
Madagascar? You've never seen King Julian?
I've not.
No
What?
idea what you're talking about, but
Oh my God, guys. What? Okay, so first of all, Bailey, your next movie night, I think you should select Madagascar, but also just can you guys go YouTube King Julian for a minute? Because basically, he's the greatest. And if there's ever a cartoon character that embodied the essence of an anesthesiologist, it is him. Like there's one where he's like, can we all like, wrap up this pointless meeting so I can get back to my schedule of not being around you guys? And oh yeah, I'm gonna put that in my next work email, like
Yeah.
100%. Yeah, those are my favorite
nice.
lemurs. But let's see, what other species? Obviously, fish, clove oil. Got that question wrong earlier on Jeopardy, so that's really demoralizing. What else? No, I think
Put some cloves in here. Maybe I'm getting anesthetized.
you obviously are because you've gone from being like obsessed about inhalants to all of a sudden like trying to create this TIVA revolution. So that's exciting. But yeah, I
You're
think
such a rebel. Such a rebel.
Really revolutionizing veterinary anesthesia by being like, hey guys, let's do TIVA more than once a
yeah.
month.
And the more eggnog we drink, the more awesome Tiva's getting. No, I think my let's say my dog thoracotomy.
Yeah. Yeah.
Mhm.
Great case.
I'm gonna rock ketamine, propofol, fentanyl, and I'm probably gonna do ultrasound guided parasternal to block the line. I might do a high volume opioid based epidural for some extended post op care. I'm trying to minimize my systemic opioids. I'm not going to use any inhalant. Go.
Yeah.
Yeah. Unless the surgeon is to sniff.
Yes. How are you gonna?
Okay, so the surgeon
I'm
shouldn't
kidding.
be sniffing as the technique. I mean, I just,
I had to bring it up.
I just, nobody out there, if you're listening, if you take one message home other than cracker pizza sounds disgusting,
No
is
way.
that
No
please
fucking way.
do not do sniff tests in any capacity for inhalants. Don't sniff to see there's a leak of your tube. Don't sniff your machine. Stop sniffing, because by the time you can actually smell the inhalant, your exposure is like 25 times the recommended daily dose.
Yeah.
Please stop it. Please stop. And if you guys look at those old papers, like even in the 70s and 80s, where they were looking at like long-term outcomes of human anesthesiologists and how many of them were like curdling up from like hepatic cirrhosis and long-term halothane exposure, you would really think twice about your little sniffing techniques. So yeah, ixnay on the sniffing, ixnay on the cracker pizza.
My protocol is I usually do propofol, dexmed, and ramifentanil or fentanyl in dogs, for example. And that's usually for any procedure, really. Exception maybe, if you have like a patient with increased intracranial pressure, not because of the dexmed, like we know that dexmed does decrease intracranial pressure.
Yeah.
There is a paper in 2006 about it, but it may mask your Cushing reflex. So that's the only reason why I try not to use it. I prefer ramifentanil because of how high you can go and how much sparing effects it has. And then when you turn it off, it's gone. You don't have to worry about, accumulation and, dysphoria post-op or anything of that. But if you don't have ramifentanil, fentanyl works just fine.
I mean, yeah, I think we should probably speak to like TIVA and also like, your context sensitive, like half times things too. So my decisions on my protocols or like whether I'm going to use PIVA versus TIVA may also depend on duration of procedure and like what's going on pathophysiologically with that patient, right? Because I'm not super keen about like 15 hours of fentanyl because waking that patient up is going to suck.
Oh, yeah.
But yeah, for the most part, luckily in vet med, like we don't separate conjoined twins and we don't do major organ transplants. So we're not usually in there on like, a 29-hour straight procedure. So once in a blue moon, I'll be like, ooh, this really geriatric, super morbidly obese patient. Maybe we should start titrating the propofol down after 4 or 5 hours. But yeah, but for the most part, yeah, I think. Now, Beanie, I have a question for you because I know that there's a certain population who's going to listen to the podcast is going to hear that this is slightly off topic, but that you're using like Remy and Dexmed together and like your thoughts on cardiac output. Because like I have a handful of anesthesiologists that I know personally who absolutely will not give fentanyl with Dexmed because they think it hammers cardiac output to the point. It's just a discussion.
Okay, sure.
You can't see his face, everyone, but it's extremely judgmental. And I'm not saying this like, you know me, like I would just be like, is the heart beating? Are you oxygenating? Move on with your day. Like, I don't care. But yeah, what are your thoughts on that?
Sure. To be honest, I think that if you're not giving a bolus of ramifentanil, you're not seeing a huge drop in cardiac output. I usually start it and I don't really give any bolus, right? This is the drug that I usually do not bolus. And if you do, it's scary, right? The heart rate drops dramatically, capital D dramatically.
And they stop breathing.
Yeah.
Yeah. Yeah, well, I mean, usually they're on a vent anyway if you're doing DIVA.
Yeah, I was like, side note about remifentanil, if you're going to turn it up to the point where you don't need inhalant, you need to have a ventilator to our listeners. I know you guys know that, but just,
yeah, just FYI, you do need a ventilator. And, the Dexmed too, like if you're not bolusing it, seeing a huge drop in cardiac output either. You know, I I never had issues with it. Blood pressure is always good. That's the only way that we have to measure perfusion at the moment. It's a surrogate. We're not really measuring perfusion, but I can't really measure cardiac output on a daily basis. So the truth is that I can't measure that, so I don't know really. But if blood pressure is good, I'm okay.
Okay.
I'm not overthinking it too much.
Yeah, and if they're not
Um,
deep enough, you can always give the miracle drug gabapentin. Like, I'll fucking knock them
sure,
out.
why not?
Yeah.
Just
Yeah, just
yeah.
like Christmas sprinkles. Yeah, just give them gabapentin and it'll be fine. I have a funny story about gabapentin actually. So my surgeon was working while we were still finishing up my hospital. My surgeon was working in the pharmacy, right? And he was sat under the letter G. And he actually ended up, he's like, I can't work here anymore. He was like, people go in to get gabapentin so much that he's like, I lose my thought like every 3 minutes. And I was like, look, guys, we're overusing the drug if the surgeon has to move where they're sitting. Like, I mean,
Oh, gee.
but
Yeah.
anyway, yeah, I think, okay, no, I was just, thinking what your thoughts are. Cause like I said, I mean,
I
one of
mean,
the,
the sparing effect you get is huge
oh
from
yeah.
Oh,
it, right? Like, it's huge.
in fact, you could probably just turn off the
Listen,
inhaler.
guys, if you turn any of the injectable drugs up enough,
It turns into TIVA itself, right?
I was like, it's 100% sparing because when your heart doesn't beat anymore, you don't need any inhalant.
Oh
Yeah. I could turn this drug up enough and it will be super max sparing.
So I feel this conversation is focused on dogs and cats,
Yes.
where TIVA is actually a mainstay technique in equine species, for sure. Like,
100%.
Well, standing, right? I mean,
but even recumbent, you
Triple
might do
drip.
triple drip. You can do like ketamine xylazine repeated infusions and get like a castration done. I mean, those are quick
Yeah.
procedures, but like it's TIVA
Yeah.
for all intents and purposes, right? Like,
fair, yeah. No, I
Yeah.
and
mean, I always run horses at minimum PIVA. Like, I'm not an inhalant or bust kind of gal for anything because that's a shit recovery. But yeah,
and
Yeah.
it's just an interesting comparison because like I think we think about this in like our very fancy like we're doing propofol remy for dogs and kind of like taking from the human side and like these really kind of TCI type things, but like we were teaching students daily TIVA techniques in equine species every single day. And
Yeah.
TIVA is still, at least in America, at least in American institutions, it's still kind of reserved for like, okay, it's a craniotomy, it's an open lung case. Otherwise, like it's a resident who wants to try it to see what it's like. But like,
like,
yeah,
yeah, like it's not LSD, guys. Like, it's
yeah, oh no,
it's not like something you just experiment with college and then just leave behind like when you grow up. But no, you're right. No, Bailey, that was your real mic drop moment. I think you've been saving that. That basically,
there's a
yeah,
whole
we've been
note on my
teaching.
computer. I've got ready for this, so I came prepared.
Of course you did. But yeah, no, you're right. We've been utilizing and teaching TIVA on large animal side since the dawn of large animal medicine. And but like we treat it like this, it's like the dishes that you only take out during the holiday, right? Like holiday theme. But yeah, like you only take out your TIVA for like you said, like very like specific things. But
Yeah,
your question is valid in the sense like why? Why do we do that?
right. In humans, it's not. In humans, it's a daily occurrence. It's on the whim of the anesthetist or sorry, anesthesiologist or the anesthetist, I guess. And like they like the recovery. This person has PONV. Like,
I think I need to practice more whim anesthesia. I know my technicians will love that. Like I'll just be like, just on a whim, I'm going to do this today. Yeah.
oh, I haven't used XYZ in a long time. Like Beanie, I'm sure does it all the time with his students. Like the student comes with the exact same plan 5 days in a row, and you're like, all right, let's change one thing today. Maybe we won't use midazolam as the co-induction agent, or
We'll use
maybe
diazepam. Dun dun dun.
Dun, dun, dun.
like just like
Nice.
it it does get a little rote, like if I'm being honest, and it helps to expand people's knowledge and help just deepen their skill level because not every
Yeah.
case is going to be straightforward and respond the way you think it is. And so like yeah, sometimes we have to do things essentially on a whim because we need to, as long as it's and you and I and all of us know this, there are very, very few absolute contraindications in anesthesia for our veterinary patients. And so as long as it's safe, for that
Yeah,
patient.
yeah. No, absolutely. I agree with you. Like, um, I don't know. Sometimes, people get comfortable, and that's what they do, and that is it, right? Sometimes it's easier to not think too
Yeah.
much. You know what I mean? Like, just to not
Well,
put
those
too much
people become
effort.
surgeons, but
Ah!
Nice.
yeah.
All
Um,
right.
I
Do
mean,
not
the
put
other
that,
thing
do
that
not put that in the promo clip. You always put me saying something dicky in the promo clip, but yeah.
Like, have
I
a
mean
copy.
that attracts viewers.
Yeah, but no, I think, yeah, no, I mean, on the other flip side of the coin, though, I do think there is something to be said for, you know, remembering that most vets and to a certain extent veterinary technicians maybe get 10 business days of anesthesia training and then they go out. They're limited in their ability in terms of the drugs that they're available to them in practice. And I do think there's a lot to be said for if you do something over and over, you actually become safer because that.
Oh, yes.
Yeah. And so I have no problem. And like, so when I was a resident, the surgeon used to say that I only anesthetize things with a Bartini, which was my classic cocktail. It was a Bartini, which was like fentanyl, propofol, ketamine, right? And he's like, I don't know why we even need you, Tash. He's like, let's just Bartini everything. And I'm like, look, you could probably anesthetize 99.9999% of every patient with this cocktail and you would get away with it. Like,
Yeah.
and that's
Or
also
with any
true.
cocktail.
Yeah, like,
Yeah.
and that's true. Like, you could switch it to midazolam, you could switch it to methadone, you could, blah,
Yeah.
blah, blah. Like the safety margin on our drugs and our protocols is super high. But I know I'm not sure everyone has the capacity to quote, experiment and think, but we do. And so I'm gonna come in like on Friday when I'm next on clinics, and I'm just gonna be like, today is a day of nothing but whims, right?
Oh, yeah.
Like,
Well,
I'm gonna
for
whim it, and I'm just, you know what I'm gonna be like. You know what? Today, guys, we're going to do an atracurium CRI. Like, buckle up.
hell, I mean, we've been doing I've been doing some of our CTs on propofol TIVA just because they're quick, they're fast, recovery's
Yeah.
better that way. You have less chance for an ISO dysphoric recovery. Um, it's a technique to get people exposed to. So when you're doing bronchoscopy, they're exposed to it already before it's a bronch. The case is not doing well, and now they're doing TIVA and they're uncomfortable. These are straightforward CTs, and some of the techs have really picked up on that and they've started using it and they're like, oh, I want to do this like CT rhino. And I was like, okay, well, let's try it out. Or like, hey, I want to do an endoscopy. And I was like, all right, well, let's see how it goes.
I mean, it's a lot better option than just constantly like, because people are always like, well, we're going to sedate it with this and then we'll top up alfaxalone. And I'm like, why don't you just sedate it properly? Or
Yeah,
just you put it on an infusion pump. Like, why do you keep running in there every 15 minutes to top something that drives me fucking crazy?
that, that's what the robots are for. That is why we made robots.
God damn it. And I'm going to put in a cost request tomorrow for an anesthesia robot. I'm sure my CEO will love that. But yeah, I would rather than be on the propofol CRI than people being running in and out doing these bolus top ups where the patient goes transiently apneic and then like, oh, we went blue and I need to intubate. And it's like, oh my God, oh my God, oh my God, oh my God. Like, yeah, be better, be better.
So, all right, the elephant in the room.
Yes.
What do you do for cats?
Boom.
Sound effect.
Slam the laptop shut and leave.
Did you notice how we all gently skirt? I mean, I would rather talk about lemurs than cat Tiva,
Oh,
but
I know. But what, have you, I think it's have you done it? Have you had success? What do you use? How much do you worry about red blood cell oxidative damage with
Oh, that's
propofol?
bullshit.
No, but I wanted to bring it up because it's reported out there. It is dogma. Like people believe it. I
Pauline
know.
Taylor made really good studies on it,
Yeah,
and you know, yeah, we do know that you need so much fucking propofol,
yep,
multiple days in a row,
yeah.
multiple infusion. Nobody fucking does that, right?
Exactly.
So
It's
like,
multiple day, multiple infusion crap. I'm like, it's multiple days and multiple infusions. It's not one infusion for a couple hours. Like
right
we know
now,
that.
alfaxalone Viva. in cats, good luck, because it works. But
Oh, yeah.
then the recovery, it's super long, smooth,
Oh, yeah.
but super long, right?
But
And so that's a problem. Propofol, if you do 1 or 2 hours, is fine.
yeah.
Above that, the
Yeah.
recoveries can be slower, right? So
I would say the vast majority of my cat TIVA protocols are going to have dexmedetomidine.
Yeah.
Right? That's actually usually the crux of my, like, dexmedetomidine, maybe an opioid. Ketamine I have no issue with. Propofol I have no issue with. Alfax, depending on what we're doing. But Dexmed is probably the one that I really like in cats because, I mean, it just buys you such a smooth plane, some
yeah,
cardiovascular stability. It's synergistic for analgesia. It has a visceral component to it. Like, they don't wake up like, when they wake up from fentanyl and they're just like, and you're just like, oh my God, oh my God, oh my God. And then you end up bolusing Dexmed. But if you have the Dexmed on board, they tend to wake up with a much smoother recovery. So that's the crux. Like, what I spin around my Dexmed, but Dexmed for me is usually the core of the cat TIVA.
yeah.
Yeah.
I
And then
think,
you have a limit. Like in equine species, we think of
Are we still
TIVA.
talking about TIVA?
Yeah, sure.
I was like, oh, I got a lot of limits, Bailey. My limit
Well,
for surgeons is you could fit in a shot glass. Um, but I was like, we're still talking about TIVA, right?
yeah.
Okay. Do I have a limit for my dexmedetomidine dose in a cat?
No. For duration, like so for instance, for equine procedures, we tend to think of TIVA greater than 1.5 hours is going to have a significant chance to really decrease recovery quality and lead to some potential complications in recovery. And for cats, we think of hepatic metabolism as limiting, or at least I have always thought like we limit cat TIVA to like an hour to maybe 2 hours because the drug is going to accumulate because their hepatic metabolism is different and the kinetics become much less predictable. And it, like to Beanie's point, it really prolongs recovery time. So do you?
Well, just put them on remifentanil. It's instead of a Bartini, it's a
wow,
Barbini.
Oh my
Jeez.
God. Ugh.
Love it, love it, love it.
Womp womp.
Yeah,
If it wasn't expensive, I would do remifentanil on every single patient.
sure.
You know,
It seems like
that
that's the way in human medicine. Seems like it's just Remy
it
for everything.
is. Yeah,
Funny.
it's legit.
Yeah.
Yeah. So, yeah. Do I have these hard cutoff limits? Not necessarily,
Yeah,
because what's the evidence?
Right.
What's
I mean, there is evidence that infusions do, especially from Alfax. I can think of a paper off the top of my head from Davis that alfaxone infusions do decrease or like increase recovery time, at least in cats.
Yeah.
oh, I've
Bruno
witnessed it.
wrote that up for sure.
Yeah. No,
Yeah,
we do need some sort of sound for when Bailey cites Davis. Like,
I'm working on that.
I
This,
know it's like maybe like the sound of a super antique car horn or something so that we can signal when 1945 anesthesia quotes are coming. But yeah, no, I think there is some evidence, but I'm like, who's to say in a cat that the difference between 2 hours of propofol and 2.5 hours, like,
Right. Totally. Yeah.
and my
yeah,
surgeons, to their credit, underline this moment, are wicked fast.
Yeah. And so you and I are coming from private practice where things tend to be a little bit faster than where Beanie's coming from, where it's going to be, more academic. So there's more
yeah,
learning for everyone involved. So things tend to be slower overall. So there's definitely limitations that Beanie experiences that we don't, and vice versa, for
Yeah,
sure.
no, we actually practice different anesthesia in the sense that
Yeah.
we practice short duration procedure,
Yep.
and Beanie probably has more protracted
yeah,
anesthetics because it's a training facility. So
Oh yeah.
I think that's a really great point that, our techniques might not be mutually applicable because it is different type of anesthesia, right?
Absolutely.
Right? Like my
Absolutely.
my
yeah,
surgeon's going to get in there and whip out like a spleen in like 15 minutes,
Yeah. Oh, for sure.
right? So
Yeah.
why
yeah.
would I even put isoflurane on?
Ugh,
Right? Why would I bother?
if only. Sometimes it's
The
like slap their hands away from the vaporizer, like
I
Antiva.
mean, the vaporizers I mean, the ones that are made of metal, you could hook up to like a small electrical shock. Good old tech-free vaporizers that you could just, like don't touch that.
Yeah.
I mean, we have expiratory gas analysis too, right? And like
Oh, yeah.
at some point, I dial my inhalant down to the point where I'm like, just turn it off.
Yeah.
Right? Like,
Yeah.
I'm just turn it off.
Yeah.
This is stupid, right? But what I'm doing is I'm weaning the comfort level of the anesthetist as opposed to my own, because
Yeah. Absolutely.
they get very, like, I
Yeah.
definitely see that look of pain. Like, I've got a slightly newer team at this job, like younger techs, less anesthesia experience than like some of my previous jobs where like I had like VTS, really senior technicians, and we worked together for a really long time, like really heavy caseload. And so, yeah, they would be like, we don't need inhalant. And I'd be like, God, no.
Oh,
But these guys are still like, it's still a transition period for my training. So,
yeah.
Yeah. I mean, what a lot of people don't realize is that we don't really know how inhalants work either. We have no fucking clue. 100
Yeah.
years later, we have no fucking clue how inhalants actually
and
work.
also that statement,
You know?
like I hear myself saying it sometimes too, where you're like, well, alveolar concentration is proportional to brain concentration, and that's where the site of action is for inhalants. But I think that statement is such a gross oversimplification, like to Bailey's point earlier, where he's like, if you've got lower airway disease, what's your cardiac output? Like, there's so many micro factors, you can insert Bartel's favorite expression, like fancy guessing, like we don't know what the hell's going on. And you can have like a good expired, percentage of your inhalant, bearing in mind that, of course, doses are averages, which is another thing that I have to say all the time too. But, it may be that that patient is your 3 standard deviation outlier,
Yeah.
and your life would be a lot easier if you went to injectable.
Are you willing to turn the vaporizer to the 3 standard deviation? Are you willing to make that like, no way, no fucking way.
No, isoflurane is
Right
the
in
root of all evil. The more you dial it up, the more everything goes to shit. So
Yeah.
why would I do that?
Yeah. And that's where propofol just comes in like an angel from heaven, and you're just like, here we go. Grab the
Like,
bottle.
So it's
like
so
ketchup
heavenly.
on a hot dog.
No. No.
Yeah, no, our regulatory college will has to have something like in our mandate about certain food rules. Like why don't you just make pizza crackers and stop spoiling pizza? Gotta be the fucking quote of the night for sure. But yeah, I think, yeah, like I forgot what we were saying because I got distracted by propofol and ketchup.
Standard deviation.
Yeah, I was like, oh, I threw myself off my own game with ketchup. But yeah, I think there's too much that we don't know about inhalants.
Yeah.
They can be a grade A pain in the ass. The more you
Oh my
dial them in, and the thing is too, is like this. The other thing that drives me crazy is like people are like, well, I felt like his plane wasn't deep enough, so I went from 1 to 1.2. And I'm like, well, in 40 years, when that
Okay.
kicks in, but still makes no clinical difference, could you let me know? Right? Like, I'm like, why are you not controlling depth with injectable when it's more predictable, more
Yep.
reliable, and faster? Like, why are, like, don't, I
Yeah.
think, I'm serious, don't touch the.
My goal is to never touch the vaporizer during a case if I can get it to like just to dial it in with all like with blocks or co-infusions or whatever, where I can just like sit and monitor and actually watch the patient, and not like my job is not to be a vaporizer jockey. Like
Yeah.
I love that vaporizer jockey.
that's why I hate, maybe this is a spoiler for my next topic, but why I hate Bane circuits, because it's just it's just like
The
one more
bane of
time.
your existence.
Yeah, no, truly. I despise them. I wish
I don't have a
never.
strong emotion about this. Like, what? Okay, well, this is another topic. This is another
Yeah,
topic. But I'm like,
Yeah.
normally we all
Don't
get
spoil it.
upregulated about the same shit. But I'm like, you guys are like really like laying into Banes, and I'm
I could
like,
do a Bane and TIVA.
Boom. Awesome.
yeah.
All right, guys. I think we're coming up on the hour. This is
Well, we
degenerating
drank all
real
the
bad.
eggnog, so
Yeah.
The eggnog is
I feel like my
gone.
topic was great and really provoked some thought, but I think the thing is we love it and we realize we need to use it more.
but the Bane or the eggnog? Yeah, no. I think we should have a
I
cocktail
can
theme
just
for every
feel you.
podcast with the disclaimer that if you follow our advice and anything bad happens, that's on you.
Just fill your vaporizer with eggnog.
Oh, can you? Oh, Bailey would be happy because his life's goal is to obstruct his coronary arteries. So that like we'll put him on eggnog TIVA, and he'll just fuck. Yeah.
We'll find out.
What a way to go, Bailey.
1-year-old eggnog sitting in the back of my fridge, fermenting or whatever it's doing.
Jesus Christ. Why don't you die? Like,
This will be my last podcast, everyone, because I'm just gonna.
Tomorrow you're gonna
I
kill
need
over
to
some
find somebody
eggnog.
else because you're going to die.
No, it's supposed to be one of those things that like you can age eggnog, right,
Yep,
Bailey?
that is what you're supposed to be able to do.
I doubt it. That's
We'll find
real.
out. I'm working on this year's already for next. No,
The
nothing.
Costco one goes bad in 2 weeks. So, I
The
don't
best thing
know.
about eggnog is that my dad, like, he boozes it up for sure. Like, I don't know how many bottles go in that bowl, but my favorite thing is like just eggnog breakfast.
Yeah,
Like, well, Americans don't have Boxing Day, but on December 26th, for those in the Commonwealth, eggnog breakfast is the best. So,
Awesome. All right. Well, thank you everybody for listening. I guess next time it's my turn, right?
it
For a
is.
yeah,
topic?
and it will be the
It
new
is.
year. Um,
It's true. It's
Yeah, and
true.
so wishing you guys a super like whatever holiday that you choose to partake in, even though I know both of you celebrate Christmas. So Merry Christmas. And to everyone listening, whether you celebrate Christmas or Hanukkah or Kwanzaa or what have you, have a happy holiday.
Happy holidays, everyone.
Happy holidays.